Hi, Dana.
Hi there. How are you?
I'm well. How are you?
Very well.
I'm so happy that you're here.
Very excited to be
Like
with you and your listeners.
selfishly happy. I feel like I get
Oh,
to ask you all my questions today. So why don't you start by telling us about your company and what you do and how you got there?
okay. So I am a family nurse practitioner and I've been in medicine for a couple of decades now. So primary care, family medicine, cradle to grave. And then I'll tell you how I got specifically to my current passion, life passion, which is managing the health and hormonal care of women in midlife, perimenopause to menopause. So about age 35 to women in their 60s, and then stragglers on both ends. So the practice is a virtual telemedicine practice for California and Nevada, and we're quickly expanding eastward to other states, which is really exciting. And then how I got there was my own personal journey through
Mhm.
the healthcare system and just realizing how broken things were and how hard it is for women in this age group to get the care that they need.
And when you say we, who is you and who is your team?
So Thrive Midlife Medicine is a medical practice. So
Okay.
we have all the different levels of people that it takes to make that work.
I love that. And so what was your first experience? When did the light bulb hit of like, I need to make this happen better? How can I change this?
Mm. So I, again, being in family medicine, I've taken care of women for a very, very long time, including women in this phase of life. And thinking I really understood what was happening to them until it happened to me.
Mm.
And for me, and I gave, the care that is expected and that is primarily, I think, how it's practiced. I just learned that that is really not the best way to provide care when it happened to me. So, what happened to me was a few years back. I had a lot of things changing in my life, including gaining a lot of weight, a lot of brain fog, couldn't sleep, low levels of agitation and anxiety, being really frustrated and irritated with people.
I'm like, check, 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 check.
Yeah, exactly. And most of that I just excused away, thinking, life is tough, and some of those people deserve my frustration. But a big thing too is I was really losing a lot of my joy, and for my life that had always been just a thrill ride. I just love what I do.
Mhm.
But actually, none of those things I made the connection that had anything to do with hormones or perimenopause. Like I said, I just either assumed I was doing something wrong, or I wasn't trying hard enough, or again, maybe they deserved it. But
I like
what
that theory.
actually, well, life is complicated.
Yes, yes.
Yeah. So, what actually sent me to the doctor's office, though, was my blood pressure. It was going up, and which was scary. And I had never had high blood pressure before. I associated it with because I was doing all the things right as far as eating and exercising and stuff, although I wasn't sleeping. But I thought there was a little nugget in my head that said, I wonder if this has something to do with hormones, which was the only thing I made the connection with. So I waited weeks and weeks for my primary care provider appointment to get this addressed. And I got to that appointment and was promptly dismissed, basically, that this is not what's happening. I can't help you. I'm uncomfortable with talking about hormones, and here's a blood pressure pill. So
Whoa.
I
Can I ask
left.
one
I
quick
left.
question? How old were
Yes,
you at this
please.
point?
In my early 50s.
Okay.
I had suffered for a while
Yeah.
before I made the connection. Actually, looking back now for years, and I
Mm,
had no idea. Sometimes it can happen so slowly that you don't know how far off the baseline you are
yeah.
until you get to the other side and can see it very, very clearly.
Yeah.
But I left that appointment in tears and felt really dismissed and pretty devastated. Just it was an awful feeling. I didn't go there for a blood pressure pill. I went there for to find out what was going on with me and to get help, more foundational help. But one thing I want to point out that really stuck out to me was I walked into that appointment with kind of an even footing with that provider. We are colleagues. We take care of the same patient population. We have very similar training. So I say that to point out that I walked in feeling empowered, having the language, knowing how the system worked, asking for what I wanted, basically, and I was still dismissed. And that was one of the first light bulb moments where I thought, if that happens to me, what do other women have to go through that don't have that same level footing when they go to the doctor's office? So I'll make this next part kind of quick. I went to a couple of other providers. I went primarily OBGYNs because aren't they the ones who are supposed to take care of women?
Mm-hmm.
And the same thing happened again. And these are highly regarded OBGYNs. One of them from highly regarded from Stanford. The first one said, here's a prescription. Didn't really talk to me about what my goals were, what my symptoms were, what was really happening. She did give me some help and I did feel better a little bit, but I later found out that that particular one size fits all approach is what she gave me was exceedingly outdated, that none of us who know what we're doing would ever prescribe that.
Can I ask what it was, or do you not want to say?
That might be a little tangled in
No
case
problem.
people are,
Yeah.
but it just is not what
The
those of us
standard.
who,
Yeah.
yeah, I
Okay.
don't want to, my goal isn't to disparage,
Sure.
but a certified menopause expert would not prescribe that. So the next one I went to, she did give me a little bit more elevated level of care, but again, very one size fits all. I was pretty prepared for the next appointment and I wanted to talk dosages and routes and different options. She said, absolutely not. And it's just so I left there, and that was
Jeez.
when I had a light, a fire lit under me, where I thought this is so terrible for women, and that's what set me on this journey to change my practice from family medicine to just helping women. And
Mm.
I took every class, I got certified, read every bit of research I could find, continue to collaborate with associates across the country where we share cases, conventions, just everything I could learn. I feel like I've learned from some of the very best in the country, and then that inspired me to create my practice. Which is only helping women in this space. But the joy, the end part of my story is I did end up with one more primary care provider. I ended up switching, and I walked into that appointment. She straight up said, "I don't know." And but she was willing to hear me, to have shared decision making, to collaborate with me, and she continues to be my primary to this day,
Mm.
and has given me great care. So there is hope. I think if women recognize that maybe hormones are part of what's happening, if there is something that's making them not feel like themselves again, and that if they do persist and they do ask the right questions and do feel empowered to recognize that they are part of the healthcare team, their own team,
Yeah.
that they will find the help that they need and get to the other side with getting all their joy and zest for life back.
I'm just listening to you and I'm thinking about age-wise. It's so hard. For one, to consider 35 midlife, I think is hard. We're not used to like it's just that's you're not thinking, am I midlife and am I 35? Like some people haven't even started thinking about family planning at that point, right? Which is a whole nother set of issues, but like it's hard to be both geriatric and midlife and
Yes.
postpartum and perimenopausal, right? And it's this very nebulous time. And I don't know what we do. Like, I think we're starting to make some strides in terms of changing the terminology, like geriatric pregnancy, but is midlife like too, think people think about menopause as your 50s, not your 30s. Even though perimenopause is its own thing and very different from menopause, how do we sort of get this normalized, I guess, in terms of age and timing and when should we start getting checked for these symptoms?
Yeah, that is such a great question. And I love that you called out all the different all the different headings and terms that we are put under. My first suggestion would be to instead of having these umbrella terms, just looking at ourselves as hormonal creatures.
Mm,
From the very beginning to the very end, hormones are just so impactful in our lives. Whether we're reproductive or post-reproductive years, we need to be seen as women through that lens. We are not tiny little men. Hormones are just, they play part of every bit of our lives. So that's the first thing. And I think if we look at women in that way, then we can get past like 35 as midlife. Like,
right,
really?
right.
That just sounds ridiculously young to me as somebody in their 50s. But just to back up a tiny bit, menopause, which is the definition of that is 12 consecutive months without a period. And that is just one day. Once you've gone 12 months, that day is menopause, and now forevermore, you're post-menopause. And that happens for about 80% of the female population in the United States. Every country is tiny, tiny bit different, but for the United States, that happens for most of us between 45 and 55.
Mm.
And we know that perimenopause, which is the time of hormonal change and potential hormonal chaos, can happen about 10 years before that, sometimes a little more, sometimes a little less. And so, doing the math, if you're 45 and have your last menstrual cycle, then 35 is 10 years. And that doesn't mean everything shifts overnight. It can be the symptoms can be gradual or dramatic, but the hormonal changes they don't happen overnight. So I like to put that framework in. Yeah, geriatric pregnancy, and I haven't even thought of having kids yet.
Exactly. That's what's
Yeah.
so, it's very hard, these like labels that are put on us.
Yes.
So, how did you ultimately come to find, like, to creating Thrive Midlife?
Uh, it became something I could not do.
Hmm.
I've never felt so passionate about anything in my life. Just recognizing the suffering and the dismissal of women in our healthcare system, which is a whole nother conversation.
Yes.
Yes, we tolerate a lot of suffering in women that we don't otherwise in the rest of the population. But I am not an entrepreneur by, that is not my character really.
Hmm.
But I just felt compelled. So even though I'm one person and then I have my colleagues and we only have how many hours in the day and can only treat so many people, part of that mission is like what we're doing today, educating and planting seeds, empowering women. So I spend a lot of time educating, whether it is through these fabulous conversations or through more structured teaching with webinars and virtual meetings where women can get educated. Everything from just foundational information, what is happening, why is it happening, things that might be happening, and then how to go about getting some of your questions answered and finding somebody that can help you. So that is the more foundational piece of those educational things that I like to do. And then there's more specific, targeted education. There's a lot of sexual dysfunction. There's a lot of mental health changes that happen. The physical body, the weight gain and the blood pressure and the high cholesterol and those things that go along with hormonal changes, they deserve their own individual conversations. So caring for patients as many as I can fit into the day, and then just spreading the word so women can look at themselves through this new lens of our hormonal existence. Because I think that as a culture, women we tend to take on so much, and if when things are not going right, we just try harder, work harder, do more, and that is kind of how we're socialized, I think. And I'm generalizing for effect, but I think a lot of women can recognize that.
Yeah.
And and then it gets to this tipping point where I can't try any harder. I can't do anymore, but my life doesn't feel the same. I don't feel the same. And I just know how that feels. And I want women to maybe be more kind to themselves and recognize that there is more going on sometimes, and it's not their fault.
Mm. So, where do you even start with somebody when they come to you? What's step
Mm.
one?
Step one. Well, step one is I have a perimenopause quiz that is for somebody who's just thinking, I'm not sure if you're talking to me or not.
Yeah.
Um, Because some of the symptoms, especially in early menopause, are kind of vague. They're not measurable. There's no test. We just know we don't feel like ourselves anymore, and we don't feel like we're managing our lives as well as we did before, but we don't know why.
Mhm.
So that can be a great place to start. Just, are you talking about me? Is this a possibility? So on the website, it's thrivemidlifemed.com. There's a perimenopause quiz. It takes a couple of minutes and it's super helpful, and you get the results back right away to know if this is worth pursuing
Mhm.
potentially. Um, but once a woman does start asking those questions, like, I think this might be happening to me, there's some really comprehensive assessment that goes on. Um, I always like to say hormones aren't the cause of everything and they're not the cure for everything. So
Mhm.
taking that more comprehensive, deeper dive to see if there's other things going on. And that's everything, back to mental health patterns that can be showing up in life. And there are some labs that in this stage are exceedingly valuable because they can tell you if something else is going on. So that's a great place to start.
And how do you determine, does this person need hormone treatment or not? Like, I'd love to get in a little bit more to hormone treatment in general, and also then backtrack into how I feel like it's the research that had been done about hormone replacement therapy in the early 2000s did such a disservice to so many women, and why it's kind of on the rise now as a very popular antidote to symptoms for perimenopause.
Yeah. Oh, that's a big one, but I can't wait to talk about that.
Yeah.
Your first question was, how does a woman know if
Like,
that would
how do
help
you
her?
determine, based on this information you're getting, like, oh, I think hormone replacement would be a great option for you? What do you look at to make that decision?
A few things. So one, the diagnosis of perimenopause is really a symptom-based diagnosis. There is no test for that specific diagnosis. And so if if the preponderance of the evidence looks at like this is potentially playing a part in what's happening in a woman's life, then we talk about options. Whether it's hormones, which include estrogen, progesterone, and plus or minus testosterone. There's non-hormonal options that can be great that target very specific symptoms. And then there's so many diet and lifestyle things that a woman can optimize in her life to try to kind of calm down all of this hormonal chaos. And honestly, my goal isn't for a woman to take hormones or not. It's just to know what her particular assessment indicates, what her particular risk benefit analysis looks like, laying out the different options, and then what resonates with her, because she may not be interested in hormones or may.
Mhm.
And so one thing to, if you're looking at it from that frame, is I have these kind of three main buckets to choose from: hormonal option, non-hormonal, pharmaceutical, or lifestyle, a diet, and those type of things. If you are looking at the hormonal piece, it doesn't have to be a one-way street. All the time we test things out in medicine and see if whatever we've chosen helps. So
Mhm.
the first thing is, for a woman, she chooses what path she wants to take once she's fully informed, which is my goal. And now, if she says, let's see what hormones can do for me, let's see if I actually could feel better. And women know very, very quickly if they decide to do a trial of hormone replacement based on their symptoms. If they start feeling amazingly better, then that's likely what was happening. And, if nothing changes, then, you look at other approaches or other etiologies for what's going on. But I think currently, right now, we in Western medicine treat symptoms just in their own little silos. Like for myself, you have high blood pressure, here's a blood pressure pill. You can't sleep, here's your sleeping pill, here's your
Mhm.
anxiety pill, here's your ADD medicine, and on and on and on. But why not just see if it resonates with you?
Mhm.
If it doesn't, then of course, not. But
Mhm.
that's how I look at it. And my particular approach is to only start one hormone at a time. So you can be very quickly if that particular hormone is the one that really is going to be the most impactful for you. Um, and that might sound a little confusing, like, well, why wouldn't you just look at the labs and see which one they need. It doesn't work that way in perimenopause. Testosterone does slowly, gradually decline at a kind of consistent level or pace. But the other hormones, they fluctuate pretty significantly over the course of the month. So chasing those hormonal labs at this stage has almost no value.
Mm,
And if somebody is treating you based on those lab values, that is, in my opinion, poor practice.
mm,
So you come in on a random Thursday and your levels are all fine. So
right,
does that mean you don't get care?
right.
Um, yeah. So that is one of the reasons why I think it is such a specialized area that it is pretty misunderstood in the general medical establishment for medical training from, OBGYNs and family medicine and those folks.
Do you think that training is getting better or not quite yet?
Not
In
quite
terms of
yet.
like medical school, right? Because we have so many OBGYNs who are like, I spent a day on menopause and that was it.
Yeah, I think the number is 1 out of 5,
Mm,
say, which is 20%. They will say that they got some training. And they almost all say inadequate, but that they got some, and that means the rest of them really didn't. And that is not to say there aren't amazing OBGYNs out there,
yeah.
but they would have had to seek out this additional training on their own, like I have and so many of my amazing colleagues have.
Yeah.
But having a certain specialty, whether it's OBGYN, endocrinology, you can't really assume. They would have to have sought the training out themselves.
Mm. Okay, so let's go back to the misinformation about hormone replacement therapy
Okay.
and how that's changed. Tell us what the research was and what was kind of wrong with it.
Okay. Well, very complicated, so I'll try to give a
Yeah.
simpler overview so I don't get things too, confusing. But so the Women's Health Initiative, WHI, happened in the very early 2000s. It was keep in mind, women were not really studied until pretty recently. We were
Right, the
not included
90s,
in
right? It was
studies.
like, yeah,
Correct. Correct.
insane.
The
Yeah.
studies were done on men, on animals, on rodents, and then it was extrapolated to women. Women were not really included or at all. So it was kind of exciting. They're going to do this huge study. They were looking actually at hormone replacement therapy and cardiovascular risks.
Hmm.
Again, that's amazing. But what happened was, so they start the study, and it was a very big study. Lots of money went into it, and what they reported that they saw and stopped the study short was, oh goodness, we think this is giving women breast cancer, and that is the message that went out. It was immediately backtracked. No, 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 no. But the bell was rang. The media went with it. Women threw away their hormones. Providers stopped prescribing, and we all thought, estrogen specifically is going to give women breast cancer. I'll point out a couple of the huge failings that, again, were immediately recognized, but of course, nobody heard about. A couple things. One is the patient population that was included in the study were there was a disproportionate number of significantly postmenopausal women, in their 60s and their 70s, and I believe some in their
Oh,
80s.
wow.
I don't know the exact numbers. But the reason that actually makes a difference is that is not the patient population we typically start women on hormone replacement therapy. So that's the first thing. Um, hormone replacement therapy is really great for prevention, but not for cure. So a woman in that age group that had been a decade plus already without her protective hormones, specifically estrogen, they protect our cardiovascular system and so many other things. Disease processes likely had set in,
Mm,
and so it wouldn't have been that the hormones gave them breast cancer. It had probably already set in, or not
hmm.
probably, it surely had.
Mm,
And the same with the cardiovascular risks. The plaques had already built, the arteries, the vessels had already stiffened, and the hormones cannot reverse that. So that's the first thing, is the patient population was off. Then the hormones that were used at that time were synthetic hormones.
hmm.
Um, they can still be prescribed, but they are they mostly are not.
Hmm.
Most of us who are practicing up to the level of what the evidence shows at this time use bioidentical hormones whenever possible. Doesn't mean there's not a place for synthetic. It's just
Hmm.
that was another huge difference. Using progestins instead of progesterone. So there was some really, really significant differences. And then since then, we've had just so much research that has confirmed and confirmed and confirmed that those initial reports are completely wrong and that we have no evidence that it increases breast cancer. But with that said, a woman we all as women in the United States, again, each state or country varies a tiny bit, but American women at baseline have a 1 in 8 chance of getting breast cancer in their lives. Doesn't mean they're going to die from it, but of getting breast cancer. And so your risk is still your risk. And likely it's not going to be reduced by taking hormones. But the hormones, especially if they're bioidentical, transdermal, the different things we do now, it's not going to increase your risk.
Mm.
There are very specific types of cancer that a woman likely should not take, specifically estrogen,
Hmm.
but that is the caveat. The rest of us, it does not increase our risks.
And can we figure out if I mean, other than genetic testing in terms of like a potential BRCA gene or predisposition to those kinds of cancers, can you tell if you should not be taking estrogen, or do you kind of find out when it's too late?
Um, a couple of things. One is those types of cancers often run in families.
Okay.
And so if mom, aunt, cousins, grandma had these, and remember, breast cancer is an umbrella term.
Yeah.
It doesn't mean one thing. There's many, many, many kinds of breast cancers. So, but if one of your relatives had that specific breast cancer, you're going to know.
Hmm.
It'll be called out.
Okay.
If there is no family history, sometimes women do just want to be tested just on their own, which I suppose is a good way to go if there was some reason to think she was at a higher risk. But
Hmm.
those would be the routes to find out. Or if it never, yeah, I mean, I'm sure there's women who get a surprise and
Yeah.
they're the first one.
Yeah.
But, good healthcare maintenance screening, getting your mammograms, getting your yearly, comprehensive healthcare labs, we can catch things early if indeed you were one of the unlucky few that had no other warning signs.
Yeah. And I just ask this, and you might not know, but because so much of my audience is fertility focused, I think the additional potentially misconception or myth was that fertility drugs, because they contain so much estrogen, also can exacerbate your chances of cancer. Do we know if that's true yet or not? Would you put it under the same category as like because estrogen itself has been disproven to technically increase your cancer rate, we can classify fertility drugs similarly?
So my specialty is not infertility,
Yes,
so
I
I
know.
can I can't speak very specific to it, but I can give you a couple of concepts that I think really land as far as being kind of logical about this. So
Hmm.
females going through their cycles, getting pregnant, and then not being pregnant, huge swings in hormones, and we don't associate any of that with cancer risk. So if we're now doing this strategically to help a woman get pregnant, doing kind of what her body already does, just a little bit, or we hope does, with a little extra help. I don't understand how that is different.
It's a really good
Again,
way to look at it.
not a fertility expert,
Yeah.
but that's how I look at this. There's a lot of fear around women's hormones, whether they're her natural cycle or replacement for her health. And answering a question in that way, when you think of, okay, what are we afraid of?
Hmm.
Um, I don't know, helps kind of frame it better.
Hmm.
I hope that was a good answer
Yeah,
for
no,
you.
that's a really good way
I
to look at
rambled a
it.
little bit. Hopefully that made sense.
That's a great way to look at it. And how does estrogen specifically, since that's sort of the one that's the hot button, the one that's most prescribed, I feel like for HRT, how does it help us with things like brain fog or weight gain? Or how is the weight gain piece of it a lost cause? Like what are these hormones replacing that are helping us? What is the replacement doing to help us?
Mhm. Okay, big question. So you're right. We have estrogen is usually the queen of the party. So we have estrogen, progesterone, testosterone, and estrogen really can be the most impactful. Not to diminish the other two because they play their part, but estrogen does tend to be the queen. And we have estrogen receptors all over our bodies, in our brains, in our bones, in our GI tract, in our cardiovascular system. We have estrogen receptors everywhere. So whether estrogen is declining or swinging wildly, which
Mm,
is what is happening in perimenopause, it impacts all of the things that you mentioned. So as far as the brain goes, in perimenopause, those hard swings, estrogen actually protects our brain and keeps things steady.
mm.
When we have those hard swings, that chaos is really hard for our brains to handle. And I'm trying to make this kind of layman's terms and not
Yeah,
get too
perfect.
sciencey.
Yeah.
And so that is one of the reasons there are so many emotional and mood and mental health things that can happen, is the wild swings. And then as far as when you're in menopause and it's just a steady decline into really, really low numbers, then that's more significant, but more significant damage can be happening, dementia, things like that.
Hmm.
But estrogen is just impacting every bit of our bodies.
Hmm. And I feel like there's even now like topical estrogen for skincare.
Mhm.
Are you in, does Thrive deal with that piece of the hormonal replacement part of things?
Well, we don't sell any products. We only
Hmm.
prescribe, FDA approved, insurance covered pharmaceuticals if that is what a woman wants.
Hmm.
But there is good evidence that
Yeah.
talks about topical estrogen. There's different types. There's some compounded versions that are sold and they're great. Some women just use a little bit of their vaginal estrogen and
And throw it on
add.
there.
Yeah, correct. So,
Hmm.
so we do talk a lot about hair and skin and those physical changes that happen when the estrogen is lowering. And I'm a huge believer in topical estrogen.
Hmm. You
It
are.
can, it can, oh, absolutely. And it
Hmm.
can, think about the significant impact it has on our genitourinary health,
Hmm.
topically, and how quickly we can reverse the deterioration down there
Hmm.
and revive those structures back to their previous glory.
Hmm.
Uh, and so even though the skin is different on our faces, slight different variations, like I said, in how it's delivered, can work wonders.
Mm. Is there is back to the age thing, is there an age limit? So a lot of times what I'm finding is like women don't realize that some of those down there issues, chronic UTIs, prolapse, dryness, they're not realizing that at the peak time of perimenopause, like the 35 or the 45. They're not realizing until much later. Is estrogen support at that in later stages still recommended?
In my opinion, absolutely.
Mm.
There is a teeny tiny few women with a very specific type of cancer that shouldn't use vaginal estrogen,
Hmm.
and the rest, the research is overwhelming that it's perfectly safe, regardless of your age. And I submit that I think most of us, if not all of us, actually should use that.
Hmm.
Say at least age 50 plus. And I have plenty of women who need it before then. But like I think kind of were alluding to that sometimes those changes can be pretty subtle,
Hmm.
and a woman won't recognize really that there is changes. But I'll tell you, by the time you get to menopause, those changes they're much more dramatic, but it still can be reversed, which is just incredible. So what is happening basically is the tissues are deteriorating, the pH is changing because of the estrogen deficiency. And even, I should point out, even using systemic estrogen is not going to make that much of a difference. So we're talking about things like challenges with lubrication, dryness, pain with intimacy. Um, so that is the vaginal and vulva area. But what about the urinary system? Aren't they separate or different? They are, but the cells are the same in the very beginning part of the urinary system. So that can look like urinary leakage, urgency, discomfort like dysuria, um, UTIs, which are they're one thing when you're younger. They're terrible if you've ever had one, but our elders, it can be life-threatening.
Yes.
Elders do not feel bladder infections the way a younger person will. And that's just all women. And so what happens is they can be very, very ill before anybody even realizes there's a problem. So I believe it's either the number one or the number two reason our elders end up in the hospital with urosepsis or
Wow.
with sepsis because
Hmm.
of a simple bladder infection.
Mm.
So the research shows, I think it's a 50% reduction in UTIs using regular use of the vaginal estrogen. And I mentioned the systemic, hormone replacement therapy that we think of will not really impact that area. The vaginal estrogen, though, conversely, only stays right there.
Mm.
So it is the systemic absorption is exceedingly tiny, to almost say it's not. And so it stays local, gets those tissues back and vital again, changes all of those symptoms we talked about, and is just should be just an ongoing medication. Very, very inexpensive, very easy to use. I submit, especially our elders, like living, say, in a assisted living or anything like that. I think it should just be part of the care plan.
Hmm.
But I could talk about that for
Yeah, a whole nother
as much.
episode. Yeah.
Yeah,
So let
but
me
even
just,
for the younger women, sexual
yeah,
health really really can be impacted by those changes.
yeah.
So even younger women, we prescribe it all the time, and there's no reason not to consider it.
And just to clarify what you're saying about the systemic estrogen, based on what you're saying, it sounds like you basically, in an ideal world, if you decide you need hormone replacement in general, you would take something like a transdermal or an oral something and the vaginal because they work differently.
They
So
correct. Even
like
though
it, if I'm taking like I have my patch on, right? If I'm taking a patch of estrogen, it's not necessarily gonna target the same symptoms that my vaginal estrogen would if I were taking vaginal estrogen.
absolutely,
Okay. I think
well said.
that's a very I feel like people are finally starting to grasp the HRT, but I don't feel like that's made clear enough that one doesn't necessarily take care of everything. It kind of now that people are embracing it, I feel like it's like a cure-all for everything. Just take more estrogen, right? And so I think it's really important to distinguish which piece
Yeah,
does which part, you know?
I love that. And to even take that a step further, if a woman says, you know what, hormone replacement therapy, which we're talking systemic, it's not for me, or at least at this time, I'm going
Hmm.
to choose other options. Uh, when we do talk about vaginal estrogen, that's not usually under that same umbrella term.
Mm.
So women could, if she decides that is not for me, she could still feel really good about using the estrogen estradiol vaginal cream.
Vaginally. That's really good to know. Okay, I feel like we have to let's like rein it in only because I feel like there
Okay,
was so much info
I
here. I don't
know.
want to like blow people's minds. What do you want like for women in midlife when like what do you want them to know in terms of like when like get help now? What should they look for? When should they come to you and where should be their first step to go?
Okay, so if a woman is thinking that things are not the same as they were, I'm not handling my life the way I did. My moods, I'm less joy, less energy. I can't sleep. There's so many symptoms, even body pain. Sometimes that is the presenting
Yeah,
symptom.
someone just told me frozen shoulder is one of the symptoms of perimenopause. I'm like,
It
huh? It's
is.
like every symptom is goes under there.
Well,
It feels like
uh,
it.
if I know it feels like that. Well, it's no surprise then that women around their 50s are the largest group that are diagnosed with fibromyalgia,
Mm.
which is, if folks don't know how that's diagnosed, that is a diagnosis of exclusion. That is a diagnosis when there is no test, there is no any diagnostics that can explain why a woman's body hurts so much. And if there is no answer, we call it fibromyalgia.
Oh,
So
wow.
because we recognize she hurts, but we don't know why. And I see every day in my practice that estrogen specifically, but testosterone can be super impactful too for that type of pain. I had one lady just recently who she was on all kinds of narcotics and she'd seen rheumatology and just she hurt so much. And there was never any answer.
Hmm.
There was never a clear answer. And so we said, hey, let's do the experiment and see if this can help you. If it doesn't, what have you lost, right?
Hmm.
She had other symptoms too that we for sure were able to manage, but she forgot to change her patch, and
Hmm.
so it was maybe 24 hours. She went without her estradiol patch, and she said she couldn't sleep. The pain in her hip had come back so severely,
Hmm.
and I hate that that happened to her, but what a contrast that really makes it clear that
Yeah.
for a lot of women, this is super impactful.
Hmm.
But to get back to your question, so one thing is to view ourselves with a little bit more kindness and grace, that sometimes we don't have to suffer more or try harder. We can see if something else is going on. A perimenopause quiz can be a
Hmm.
great place and to start. And if it is answered in the affirmative, the results, maybe that can give the initial sense of empowerment to start having these conversations and not worry that you you know, sound like you should be dismissed.
Hmm.
And listening to podcasts like yours, just having women having these conversations. Oh, this is happening to you. This is happening to me too. And recognizing that there are, even though we're all individuals, there are a lot of commonalities as far as symptoms that can start happening in this space. So, and then finding a really good expert that can take a deeper dive and determine if maybe this is what's happening to you.
And
Um,
you mentioned you got certified in perimenopause. What is that certification? And wherever you were certified, can people go there to say like, here's where I live. Do you know anyone that can help me? Because obviously, if we're in California or Nevada, we can come to you. But if we're not in any of those places, how do we find somebody that can help us with this?
yeah, there's some great resources. Now, this isn't the be all end all because there are folks who are not on these lists and they can be great if they've sought out additional. But Menopause Society has a list. They have a rigorous test that they have you pass.
Hmm.
Heather Hirsch is a internal medicine physician. She founded the women's health clinic at the Brigham Women's,
Hmm.
the menopause clinic. I mean, she not only has a practice and helps countless patients, she trains clinicians.
Mm.
And so she has her own certification process as well as lists of providers in every state. Ishwish is a great source. That's a little bit more, nuanced, but sexual health is such a huge, in relationships and how they're impacted by this time of life. So Ishwish is another great resource. And then word of mouth, of course.
Yeah.
Um, as soon as a woman starts feeling like herself again, she, screams it at the rooftops. So hopefully sharing what she's gone through to help her fellow friends. And then even if somebody is not in your state, so for instance, myself, um, I have colleagues across the country that
Mm.
are well trained, and I refer people all the time, and they refer their out of state patients to me,
To
or
you.
their patients that are in California. So, it takes a little bit to find somebody, but it can be done. One other thing, if do we have time for me to say one more
Yeah,
thing?
of
Okay,
course.
is with all that said, that still doesn't mean somebody is aligned with the latest, up to date on the latest research, or kind of a good fit for you and what you are looking for. So I always educate to before you even go to your appointments, before you take time off of work and pay for parking and get a babysitter and do all of these things, when you're making the appointment, even if you think you're in the right place, talk to the person who's at the front desk. When you're making that appointment, does so and so see women in menopause? Does so and so manage hormone replacement therapy? Do you know what kind of training they have? I promise you, the girls at the front desk, they know.
They know.
Yes, they do know. So that is something, to ask and then
It's a
save
great
yourself,
point.
all of that hassle. And then when you get into that appointment, it is okay to ask a couple of questions. What is your training in this area? Or what is your experience in this area? How do you individualize the treatment? What are my own personal risks and benefits of the different options based on my assessment? How are we going to, assess efficacy and follow up? Those are reasonable questions, and I think a
Mm.
lot of women might be think that they don't have permission to ask them, but they do.
I
And
love that hot take because even within the fertility space too, people feel very scared to ask questions that literally will change and affect their lives.
yes, yeah, it's a really challenging power dynamic for most of us. I don't care how powerful you are in your regular life, and
Yeah,
it's very vulnerable space to be presenting,
it
at the
is.
doctor's office with really vulnerable symptoms and really needing help. So that's even an even more, I think, tough space in any kind of medical specialty.
Amazing. This has been so helpful, Dana. Thank you so much for being here. And we will, of course, link out to all your fun stuff, and maybe we'll have to do a part two sometime.
I would love that.
Great to meet you.
Okay, good to meet you. I really love all that you do for women.
Oh, hi, Dana.